think one of the big things we've learned, and I hope you can see the slide okay, is that in terms of thinking about the way that services work, the way that staff and care processes work, that the feedback and the involvement of service users and carers in co-designing and making those services safer for the future is a critical part of an approach to patient safety. So what we would say is that we probably could have done that better. We could have hardwired that in from the beginning, and we intend to do that in any future project. So I guess one of our key messages this morning is that co-design makes patient safety stronger.
Service users and carers bring a unique perspective, and actually that makes them good problem solvers. And as end users, we have a right to influence care delivery, and this actually links closely with national policy drivers too. So my aspiration is that it will become the norm for service users and carers to work in partnership with clinicians and co-produce novel healthcare solutions.
Micromorts, a 1 in 1 millionth chance of unexpected death. So to put it into context, 10 of those every day I get up, 10 micromorts. There's a 10 in 1 millionth chance that I will drop dead. If I'm highly stressed, that goes up. Flying to New York, 3. Hang gliding, 8. Healthcare, I work in healthcare for a day, 5. One night in a UK hospital, 75. Avoidable error. If you put all the bits together, what I was struck by is when you connect these things up, they're highly interconnected. You don't think in systems terms, in the absence of design or the absence of risk. All of them go together, and the people thinking is right at the heart of it. But if I was to say, well, what are the key parts from each? I would say the systems thing is about stakeholders. Think about all the people involved and what their different needs are and how you're going to satisfy them. On the design side, be creative. Do not provide the first solution you think of. Be creative and think about the range of possibilities. What could you be doing? And on the risk side, manage and assess the risk. Understand the levels of risk. But at its heart, it's all about people thinking. It's the people you're serving and the people who are provided to help serve. How do they work together to get things right?
As a human factors professional, what I often find is that healthcare teams' understanding of what human factors is that it's very much about non-technical skills and taking crew resource management training from other industries and giving it to healthcare teams. Human factors is not about non-technical skills training, that's one element of it. It's about strengthening systems, not only by just focusing on the frontline teams, but also by redesigning the system so that you make it safer. And that's why the SSA aspect of this intervention was so important, because it went beyond a lot of what other healthcare projects on human factors have done. And it took the frontline human factors training and delivered it alongside that systems design approach. So why are both important and why are they complementary? Well, if you only deliver human factors training and there is no focus on the design of the system, essentially all you're going to achieve is to improve the communication, the leadership, the culture within the teams, but you're still expecting those teams to work in a badly designed healthcare system. So they constantly end up firefighting. And we need to have an aspiration and a vision that goes beyond that.
Through working with our service users was we kind of understood our services. We use a lot of abbreviations, we use a lot of acronyms and jargon. Our service users didn't necessarily understand the difference between our community teams, our acute day treatment unit, our crisis teams, and who did what. So we tried to, that was one of the things we wanted to tackle. And another one about it was jargon, abbreviations and complexity.
It doesn't mean something good can't still come out of that.
So at these meetings, Fiona would sit there and discuss the findings, and it was found really with this chap, his history was that he grew up in Liverpool. He was told by his father, you should always use your fist to protect yourself, you'll be safe, and that was the upbringing he had. He then went into the Navy and he used to spar on the boats. He then became a professional boxer, and he then was a lorry driver, so it was a very alpha male kind of environment that he was in. And this was some of this information he had, but Fiona had worked with the patient as well as his son, and some of the life story work that we'd done on the ward. So it sort of gave us a bigger picture as to possibly why he's responding the way he does. And majority of the time when he does that is when he felt intimidated. Because of his visual impairment, he thought he was in his own home. He would wonder why people were in his bedroom, and the way he'd respond is quite literally just by hitting out at people, shouting.
Admission process for our admission ward, assessment ward. Somebody's actually allocated on the shift for actually dealing with an admission, so it didn't go from person to person to person. So again, we're looking at reducing that distress, which is obviously is there anyway with that admission. We then, carer support groups, we have those twice monthly now. They have grown and grown and grown, and basically the engagement that we get with the relatives and carers now is absolutely fantastic.
We should also reflect on, and one of the things we're very keen to do, despite the name, which was a name that was given to us rather than, is in the collaborative to focus on things that go well. So the 99% rather than the 1%. So what are teams doing that works? What have you tried that has made a difference? Where have things locally, even though you probably don't recognise it as wonderful, what have you done that is exemplary in the eyes of colleagues down the corridor and across the A14?
About 2 years ago, the Health Foundation invited an opportunity for organisations to bid for money to look at patient safety. All of the mental health trusts in the east of England and a number of our academic partners decided this is something we were interested in. We wanted to think about a novel approach in improving patient safety across all our services. So we submitted a bid to the Health Foundation, and this bid was successful. It allowed us an opportunity to advocate and raise for the voice of service users and carers. Our bid wanted to think about how mental health services thought more proactively about patient safety instead of reacting all the time. So for the past 2 years, we've been applying this across all the mental health trusts in the east of England. It's been a really exciting project, and we've learnt a huge amount, culminating in the event today. What we've learnt is it's really important that we sustain these projects. We recognised that learning was enormous. One of the key points, in fact, was ensuring that co-production was at the heart of it, that service users and carers had a really strong voice in what patient safety was about. We want to look at how we build upon that. So all of the organisations will take this away and say, how can we do better? Look at the learning and say, actually, we want to move that from one specific area and move it across all of our organisations and beyond.